And
thank you very much, Bogdan. Can everybody hear me at the back? Is that okay? Yeah? Thank you for the introduction. Is it possible to have the lights down a little bit at the front? My name is James Rudd, so I'm not a mathematician. I am a jobbing heart doctor from Addenbrooke's, but also a researcher with an interest in vascular imaging. And I'm really delighted to be working with John and Carola and all of the PDRAs and other collaborators in this project. I was asked to give a really brief overview of the kind of clinical problems and the kind of questions that we have concerning heart disease and where the centre might be able to help us to get better at diagnosing and managing heart disease. So unfortunately we know that heart disease is really common. It affects about 35 and in fact kills about 35% of people in the EU. Predicting individual patients that are going to have a heart attack and a stroke is really difficult. We don't really understand, despite 100 years of basic biological research, we don't really understand the causes of the underlying problem. And for pharmaceutical companies, it takes a very long time and is very costly to develop new kinds of treatment for heart disease. As an example of how bad we are at prediction, anybody know the chap on the left here? Okay, so that was a chap called Jim Fixx, an American man who popularized recreational jogging in the 1970s. He wrote the first book on why jogging is good for your health, and unfortunately died at the age of 47 during one of his runs, despite not smoking, not drinking, and living a very active lifestyle. And the chap on the right is probably more familiar to most of you. He lived to the age of 90. He enjoyed half a bottle of champagne in bed before he got up in the morning. And I wouldn't like to estimate how many cigars he got through as well. And he lived to 90 without any serious heart problems. So it's really hard just by looking at people and their lifestyles to predict patients who are going to have heart attacks and strokes. In terms of what is a heart attack, this is the heart here on the left-hand side. It's essentially a very large muscle which pumps rhythmically 60 to 70 times a minute. The arteries that supply the heart muscle with blood are shown here in blue, and this is a post-mortem specimen from a patient who has experienced sudden death because of a heart attack. And what happens is there's a large build-up of fat in the wall of the artery, and over time, and for reasons that we don't understand completely, sometimes this covering, it's called a fibrous cap, over the atherosclerotic plaque can rupture, and it allows this horrible lipid-rich fatty stuff in the wall of the artery to come into contact with the blood flowing down the artery, and that causes a massive blood clot here, which of course starves the muscle downstream of blood, and that causes chest pain and collapse, and it can lead to death. So this is the enemy, really, the enemy within the wall of the arteries. This is what a heart attack looks like if the patient has been unfortunate enough to die from it. This is the heart muscle removed at post-mortem, and you can see here there is the left ventricle with a very thick muscular wall, the right ventricle a little bit thinner, but this dark area here is area of tissue death. Heart muscle has died because it's been starved of oxygen and blood. If we go back to the picture we had of the fatty wall of the artery, we know that as well as causing narrowings, so this is where the blood normally flows, it's called the lumen, and you can see it's massively reduced because of this large buildup of fat in the wall. But we also know that there are pathological processes going on within the atherosclerotic plaque that make it more likely that you'll suffer a rupture and a heart attack. And these are things like inflammation, calcification, hypoxia, and the details of these really don't matter today. Suffice it to say that we're particularly interested in inflammation as a way of perhaps reducing the risk of heart attacks if we can lower inflammation. And there are many drugs in the development pipeline that are anti-inflammatory that might be useful for reducing heart attacks and strokes. What's this got to do with imaging? Well, we can image the arteries around the body in many different ways. We can use things like ultrasound, which is cheap, simple, quick, no radiation, very easy to do in clinic. Getting more complex, more expensive, CT scanning of the arteries here. You can see a very nice coronary artery here around the heart with a big lump of calcium in the wall, which is a bad thing. MRI Getting more complex, more expensive, but no radiation, which is good. And you can see here beautiful images here of the wall of the carotid artery, and this is from Professor Gillard and Martin Graves' group. And this is a PET scan, and this is what I've been working on for most of my career. And this is a technique that allows us to really interrogate those individual processes that I told you about in the slide before. This chap is, you can see, running into trouble, and it's put here to remind me that the problem with arterial disease is not the amount of narrowing that it causes of the blood vessels, but really what's happening in the wall that you can't see simply by measuring the narrowing. You do need to look behind the narrowings to actually find out the pathological processes within the wall to have an idea of treating it. Patients with really narrowed heart arteries don't necessarily get heart attacks, which is surprising. You'd think the more narrow it got, the more likely you are to have a heart attack, but it's not true. This is data that's been replicated many times. But 70% of people with a heart attack actually have a less than 50% narrowing in their blood vessels, just showing really that narrowing is a poor predictor of future heart attacks. So these are the kind of questions that we ask from both a patient perspective and also a research perspective that I think the centre might be able to help us with in multiple different ways. Can we use imaging of the arteries to tell us more about the underlying biology of the process? In other words, what's going wrong? Which processes are getting out of whack that are causing problems? Can we use imaging to tell us on an individual patient level who's going to have a heart attack, who's going to have a stroke, and more importantly, when? And finally, can we use imaging to test the effectiveness of new drugs coming through the pipeline? Doing large-scale clinical outcome trials is really expensive. $2 or $3 billion, something like that, to do a large study. And a lot of companies are interested in doing smaller studies using imaging as almost like a surrogate marker of effectiveness before they commit the big dollars to the larger study. I'm going to talk about, for the last 5 minutes, why FDG PET is well suited to some of these tasks. FDG stands for fluorodeoxyglucose, which is a very complicated way of talking about radioactive sugar, basically. And the fluorodeoxyglucose is used very widely in cancer imaging because we know that cancer cells seem to use more glucose than non-cancer cells. So if you inject radioactive glucose and let it circulate in the body for a couple of hours, then put the patient into the PET scanner, you get hotspots of where the glucose activity is happening. And we applied this to atherosclerosis, hardening of the arteries, because we know that the more FDG you have in your arteries, not just cancers, so the more inflammation is present there as well. This is a picture from one of my PhD students, supervised by Liz Warburton and myself, not using FDG, but something very similar. This is a patient who's had a recent stroke, and what we've done here is a PET CT scan. We've taken away all the skin and the muscles and everything, and we're excuse me, we're left with the skeleton. It'll stop in a second. We're left with the skeleton and the arteries supplying the brain. So this is the carotid artery on the right, the carotid artery on the left, and this blue-green blob here is a tag similar to FDG, which is showing us that there's an unstable pathological process just at that point in the artery. The rest of the arteries, as you can see here, have none of the label. So this is a really useful way, without going into the patients, without doing tubes or cameras inside, of being able to see exactly what's happening at the level of an individual artery. And if we can see what's happening, then of course we can measure it. And if we can measure it, then we can give a drug and measure it again to see if there's an improvement in that process. We know, in terms of prediction, we know that FDG, if you look at patients who are going through cancer screening, and you ignore the cancer but just look at the blood vessels, we know that the more FDG that the blood vessels accumulate, so the risk of their future heart attack increases. And again, the details are not important in this context. What about using this for drug development? Yes, it's possible. This is some work I did a while ago now at Mount Sinai Hospital in New York, where we showed that a common medication, a statin medication, which you've probably heard of, this is, as well as reducing cholesterol and reducing the risk of heart attacks, it's also a potent anti-inflammatory drug. So what we did is we dosed patients with two doses, two strengths of of statin, high and low, and then we looked to see if there was a difference between the two groups. And what we showed in summary was that you can see here at baseline lots of FDG activity in the aorta here, the ascending aorta and the descending aorta, and we give this strong anti-inflammatory medication and there's a reduction in the uptake. So in terms of, I've given you a very brief overview there, but the other things that we're interested in is maximizing the information that we get from medical images. So at the moment we often use images, and radiologists, Professor Gilbert in particular, will look at the images and make a diagnosis, make a decision. But we know that there's far more information contained within those voxels than simply a yes or no question. And the kind of things we're interested in are exploring, for example, the heterogeneity of tumors, the heterogeneity of pixel intensity, voxel intensities within atherosclerosis, within aneurysm. We're also interested in extracting data concerning mechanical stress, and Huang is going to talk about that shortly in relation to aortic aneurysm. One of the things that we also struggle with, we often have imaging, different types of imaging on the same patient at different time points. So we might have a PET scan in January, an MRI scan in March, and then the patient comes for another PET scan the following January. And we want a way to accurately co-register, which means bring the images into the same space, and also follow time series over time to see what happens to individual voxels over time, perhaps during treatment. And that's really hard to do, and we're hoping for help with that. And then finally, one of my other interests is integration of electronic healthcare data records. We've got a new whiz-bang system at Addenbrooke's, which was in the news for all the wrong reasons a few years ago, but now seems to be working fairly well. And we're interested in applying NLP techniques and deep learning techniques to really grab the data from there and look for correlations and things within the data, signals within the data that are invisible to us at the moment, looking on a macroscopic level. And you may have heard that recently Google and AstraZeneca and the American Heart Association gave $75 million to a single person to perform the simple task of eradicating heart disease in the next 5 years. It's going to be gone, done. I'm retiring. And the winning proposal was a machine learning approach to heart attack prediction. So I'm slightly annoyed because this is the sort of thing that John and Carola and I were talking about a year ago, and they've got 75 million quid to try and sort it out in 5 years. But on the other hand, it's reassuring that perhaps there is something in this kind of work. I'm going to hand over to Huang now, who's going to talk much more about the deep mathematics and bioengineering approach to risk prediction. Let me just see if I can do this.
Hello, my name is Huang, and I'm a postdoc researcher here at the center. I'd like to show a little more about what we did with the patient-specific modeling of the abdominal aortic aneurysm, or AAA, based on in vivo imaging. So the AAA is a localized enlargement of the aorta. It is frequently asymptomatic until the final rupture, which is then associated with very high rate of death. The current management is still based on a single criteria of the size. However, it has been shown to be insufficient. Like James mentioned, for the imaging of AAA, we have different modalities to reveal its anatomy. This includes ultrasound, CT, and MR. So there has been lots of advance here in the Department of Radiology and in medicine. However, the AAA itself is a very complicated disease, and we will need to look further than that. This could involve incorporating more functional information, such as inflammation and hypoxia, as well as digging deeper into the existing data by performing analysis on the biomechanics and texture. Of course, there are reasons why we do this. We want to look at inflammation because inflammation, together with the matrix breakdown and smooth muscle cell death, are the major hallmarks of the pathology of AAA. We're interested in the biomechanics because it's always there due to the heartbeat. It contributes to the pathology, and ultimately, a rupture itself is a mechanical event. So that's why the mechanics has been more and more recognized as an additional, or more precisely speaking, a derived modality to assess the risk of AAAs. And that is to say, when we try to study AAA, we could have a combination of different tools. So we could make use of information that are directly obtained from the anatomical imaging, such as the size, the morphology, such as stenosis, and also the composition of different components. We also have the information that are acquired from functional imaging, as well as those derived from anatomical imaging. And with this huge collection of data, we can aim for two things. The first is to understand what is going on, and the second is to better predict what is going to happen. So for the rest of my talk, I'll be showing some of our current achievements about understanding the disease to enrich our current knowledge and what we think we could potentially contribute to the future prediction. So that's about the understanding part. There are still lots of things we don't know about the AAA. One of them would certainly be the role of the intraluminal thrombus, or ILT for short. Vascular surgeons, as well as many engineers, would believe it to be protective due to the so-called cushion effect. The thrombus would separate the wall from the blood flow and hence reduce the wall tension. But on the other hand, many of the biologists would consider that to be a threat to the structural integrity as well as a major source of hypoxia. So there has been ongoing debate for decades, and actually the 4 references I use here are all from the same journal. The second question would be the relationship between the inflammation and stress. We have shown that there are positive correlation between the two in general, but still our knowledge is quite limited on that. We don't know enough about it, and we don't really know how to make use of it either. And to answer those questions, we performed a series of mathematical studies here in Cambridge. So we constructed the geometry based on the anatomical imaging, more precisely the contrast-enhanced CT. We then subdivided the geometry into smaller bricks called the finite element, and then assigned material property to each of the elements. The material properties have been carefully measured. It's showing a bit slow here, but we can see it's an extension test, and fitted in Prof. Gila's group. And once we get all the material properties, we now have a large system of partial differential equations. By solving that, we could obtain the mechanical stress within the wall. And then finally, we try to predict, try to study the relation between the inflammation and different variables, such as the conventional risk factors, smoking, diabetes, etc., as well as some of the morphological measures and compositions. Of course, we also have the derived property of mechanics. So in total, we have 21 patients involved in that study. So if we take some first glance of the data, then because we're interested in the thrombus and stress, we could already see a negative correlation between the FDG uptake, or otherwise in inflammation, and the local thrombus burden. So that's reassuring. But if we take a closer look, then we could see that there's still quite some of overshoot, even in the regions with more thrombus. And we can also see that from a box plot. The regions with ILT are associated with a lower median value of uptake. However, it also has a higher range of variation, so you also get some high values in those regions. So that then seems to back up the other side of the story. The thrombus may not be that protective at all. Another thing is about the stress. So we see, at the first glance, we see some positive correlation between the FDG uptake and the stress as the hot points here. And so this is also something that has been previously reported. But we also found that for the first time that the correlation would actually improve if we start to look on a subset where there are locally more thrombus. So if we look at the figure on the right, which has a local thrombus ratio more than 2/3, then we get a boost both in terms of the R value and the slope, showing an enhanced relationship. So these are just some first look at the data, but within further analysis using the multivariate linear mixed effects models, and we consider the FDG uptake to be the outcome variable. What we immediately see that the inclusion of a derived property, the stress, would actually improve the model according to the information theory. And what's more interesting is that there's an interaction term between stress and thrombus, which is shown to be highly significant. And this interaction term means that the same stress level may have different indications if the local thrombus burden is different. So that means we need to look at these parameters jointly rather than separately. And this kind of interaction term can also be visualized using a ROC curve. In the ROC curve, we use different variables as a test against the inflammation. And the goodness of a certain test is quantified by the area under the curve. So the more it bends up, the better the test is. If we look at the whole data set, then we can see that stress slightly outperform the others, but none of them is very good. However, we get an increase of AUC if we start to focus on the regions with more local thrombus involvement. And when we look at regions with thrombus more than 2/3 of the area, we actually get AUC of 0.8, which is considered to be a pretty good test. And the efficiency of stress enjoined with thrombus ratio can also be shown using a box plot. So when looking at that subset of data, we get a good separation between the low stress and high stress groups. So now I think we are in a better position to answer the previous two questions. One is about the role of thrombus, and the other is about the relation between stress and inflammation. So for thrombus, it's not a black or white scenario. It can be both a blessing and curse. So in most cases, we do consider thrombus to be protection because of the negative correlation we've observed. However, due to the complicated 3D geometry we have with the AAAs, sometimes the cushion effect may not be sufficient enough. And in that case, it is the evil side of thrombus which becomes more dominant, and we'll be getting, the balance will be shifted to a less favorable side, as shown here. So sometimes we have this high stress concentration even beneath the thrombus. So now I think we get a better understanding about thrombus by combining different modalities, including the anatomy, the functional, and also the derived mechanics. So it is the high extent of thrombus coupled with high stress that is a better indicator of inflammation. So that's about the thrombus. We also get a better understanding of the stress itself. So because we already see an interaction term between stress and thrombus, so I think it makes sense for us to raise the dimension a little bit and produce a heat map instead. So in the heat map, the horizontal and vertical directions stands for the local thrombus and stress respectively. And the SUV uptake is shown by the color from cooler colors to warmer colors. And what we can see that is if we look at regions with smaller thrombus content, then basically we get a scattering of warm color across the vertical direction. And that means stress perhaps isn't doing much in terms of predicting the inflammation. However, if we look at on the right side and separate that region into the high stress and low stress groups, we could suddenly see a quite difference in the colors between the two. So that again shows the power of that interaction term and shows it is necessary for us to look at the information jointly rather than separately. It is the LT coupled with high stress that is considered to be a better predictor. And this work has recently been accepted by circulation imaging. Besides understanding the disease, I would also like to talk a little more in my last two slides about prediction. So as we know, AAA itself is a dynamic structure, and it could undergo expansion as time goes on. A high rate of expansion is normally associated with increased risk. Different AAAs may expand at different rates and also in different patterns. So the one on the top stands for one type. In that type, the luminal area will stay the same or even dilate. But there are also other cases where, despite an increase in outer diameter, the luminal area would become smaller due to the newly thrombus formation. So is that a good thing or bad? Then it depends on whether you believe the protection theory or the threat theory. But then we get quite a lot of variation in the pattern and also growth rate. So the grand challenge would be, can we predict the AAA growth using the information acquired from baseline so that we could potentially direct the clinical management to allow it to be more cost effective? And that's a question we're trying to answer in the center. So we bring information from anatomical imaging as well as functional imaging. We also make use of derived information such as mechanics and texture. In fact, in the past, the group of Prof. Gilas has already showed a relationship between the stress and future expansion of AAA. And also using the software TextRad, James' group has shown a link between the texture and the clinical outcome. So there has been lots of preliminary results as well as expertise around in Cambridge. And so by bringing again together all these modalities, we hope to improve our prediction about AAA growth, to improve the prognostic value as well as the diagnostic value of current imaging. And we also hope to ultimately help to face the challenge both clinically and economically to improve our current healthcare that are associated with cardiovascular risks. That's it. Thank you.
Okay, we have time for quite a few questions.
Yeah.
Fire away. It's more a comment rather than a question. Regarding the Jimmy Fix example that you mentioned at the beginning, Jimmy Fix also was known to kind of start running by the age of 35 and was, I think, weighing about 100 kilograms and smoking 2 packs of cigarettes a day.
Oh, really?
Up to that point. So therefore, could that actually be already the explanation why he maybe wasn't so healthy in the end?
You ruined my story now.
The reason why I know that is because we had the same story in the healthcare center in Münster, and at some point someone actually pointed it out. Then I think they had to change the story as well.
Okay, I need a new example.
sorry about that.
Anything about Churchill?
Churchill is still remarkable.
You're safe there.
Maybe one actual question, because you do a lot of use FDG for a lot of like stress analysis and whatsoever, and there's also a lot of research in PET imaging in order more to detect cardiovascular disease by using H215O and dynamic imaging. Is there a specific reason why you focus on FDG rather than, for instance, using H215O?
FDG is most widely available and the cheapest, and it also happens to tell us quite a bit about inflammation, although it's not completely specific. And we do have in our group many other students working on different traces. H215O is not as widely available, and it's much more expensive, so it's not as useful to us. And it tells us really about perfusion of the heart rather than the atherosclerotic process in the wall of the heart.
Yeah.
You've done quite a lot of work on the sort of tissue side. Have you looked at how the flow patterns of the blood flow change with atheroma in the lumen?
So that is.
I was just wondering if the flow patterns changes, they could change the stress within the.
Yeah, that's a very good point, and we are working on that. Martin Bennett, who's the head of the group, has a big interest in that in terms of both mechanical stress secondary to blood flow and also shear stress, which is a parallel stress force to the wall of the artery. And it's well known that, for example, at bending points in the arteries or bifurcation points in the arteries, there's turbulent flow which creates low area or areas of low shear stress, and that seems to encourage atherosclerosis to develop. Whereas if you have areas of high stress, that seems to encourage the rupture events to happen. So there's lots of ongoing research in that area, and it's probably some interplay between the biology in the wall of the artery, the flow, and the mechanical stress that's the most important.
Thank you.
James, can you make some comment about the role of calcification?
Yes, I didn't talk about it much today, just in the interest of time, but that's another area we are interested in. You probably saw on one of the CT scans, the bright white material is calcium in the wall of the arteries. If the arteries become extensively calcified, it's felt that that is a protective thing. It kind of walls off the inflammation and perhaps helps to damp it down and stops the plaque rupture happening. But you can also get different types of calcification, really small spicules of calcium within the artery walls and also within the aneurysm walls. And that's felt to be much more dangerous. And we've been working with a PET tracer that tells us about the dangerous kind of calcium. So again, another area ripe for research and drug development as well.
Yes, in the back. Do you see opportunities for PET-MR in this setting to help with the registration of the different data sets?
Yep, we're very lucky to be one of the 6 centres who've just been awarded a PET-MR by the MRC, which I think is now installed and undergoing QC testing. The challenges with PET-MR, I think, are going to be things like attenuation correction of the PET signal. But we certainly have some promising ideas and pilot studies that we're going to try, because, of course, with MR you get much better tissue characterization than you do with CT, and also the radiation dose of is much less than with a PET-CT scan. So definitely, yeah.
You mentioned NLP, I think, at some point as well, with regards to health records.
Yes.
What sort of role do you anticipate that to play?
Well, there's been some research studies published recently that suggests that if you are able to interpret clinical notes from electronic systems, there may be data in there that is useful for predicting problems. It starts out as simple as whether a doctor says this patient has heart failure on a problem list of an electronic record. That's the simplest way of looking, but that's not particularly fantastically good. Other people have looked at the way the sentiment of the text within notes, how that might affect what happens to the patient down the line, that kind of approach. And we're also hoping to bring in other variables, so blood test results, height and weight, imaging results, and do some kind of analysis, NLP analysis, of all of that data together. I mean, it's a massive undertaking, but I think this is the ideal platform or the ideal centre to try something like that.
On that note, with your new system at Addenbrooke's, are you thinking about trying to structure the information that you put in so that it lends itself more to that kind of machine learning approach?
Yeah, is Lydia here? Lydia Drumright? No. Okay. That's a shame. Okay. So Lydia is a clinical bioinformatician who's leading on this area of research. When I've spoken to her, she's talked about doing 2 approaches. One is a sort of data curation up front, a kind of data cleaning process, hoping that that will give you better results than an unstructured data set. But one of the problems with that kind of analysis is the outcomes. We've only had the system for 2 years, so the outcome variables are not yet apparent. So we're hoping probably to start with the UK Biobank data set, which is 500,000 patients who've all had imaging, and they've been followed for quite a few years already, so they've had lots of events. So there we've got training data sets and validation data sets that we can use, but we don't have access to the kind of text fields. But we certainly have imaging, a bunch of biomarkers, lots of genetics, and hard outcomes. So I think a machine learning approach on that data would be a promising first start, then hopefully moving into more of the electronic healthcare record data. But that's certainly one of the features of the centre, and it's a shame Lydia's not here, but we are pursuing that avenue as well.
Question?
You talked briefly about the cross-platform co-registration that you're going to do, trying to bring different image types together.
Yeah.
Where are you along that sort of pathway? Is that something just starting out, or have you?
So I think some platforms are more mature than others. For example, the PET-CT, it's PET and CT in a single machine, so that's fairly straightforward and doesn't often need any manual adjustment. PET-MR will be the same. We have lots of expertise across the clinical school with people who can do this sort of work, manual manipulation of the images, warping, and now I'm getting out of my depth, but one of our approaches or hopes is to be able to not only do the image co-registration, but also, you saw some tissue samples there, to be able to back correlate, if you like, the tissue excised from the patient with the image to tell us more about what's happening. And I know that AstraZeneca have got a particular interest in that area. We're going to be working with them as one of the partners to try to bring that forward. But there is expertise already in the centre, but we're always looking for collaborators to help us with that effort.
Other questions? I have one question. One question was on NLP, but that was already been asked. So part of my work is on improving resolution and fidelity in images in general.
Right.
And one of the challenges is how to deliver the new tools to radiologists and clinicians.
Right.
Do you have the same challenge when you present new tools to clinicians? Is it in terms of just results that they can look at? Do they have to have some prior knowledge in running or knowing where to look for? What to look for?
I think it depends exactly what you're talking about. When it comes to using these tools to make a diagnosis, we have a clinical diagnosis that will affect a real patient in real time. We have to be very careful, and this is why we have things like the FDA approval processes for diagnostic aids as part of workstations. But I think if you're talking a stage before that, then yes, it is tricky to persuade people that it's going to save them time, that it's going to help them make a better diagnosis.
Right.
So a lot of these are still in the research phase. Some of them, of course, have made it through to clinical workstations on the latest scanners. For example, calcium scoring you saw there on one of the images is now in routine practice, and that started out as a research tool.
Okay. Well, with that, let's thank the speakers again.